Hi, everybody. No, I'm just kidding. I'm Tyson, one of the CRNAs that works here. And we've got a lovely teaching today on regional anesthesia. You guys already skipped the first page. I titled it A Thorough Introduction because there's a lot of information to cover, and I'm going to try and do that thoroughly, but stay on an introductory level so that we're not getting stuck in the weeds, so we can try and do a full perioperative for everybody. Okay, so just to start off with regional in general, there's lots of different anesthesia types. We're all familiar with general anesthesia and max. There's different types even within that, right? We've got inhaled versus TIVA, different levels of max. Today's exclusively about regional, which is an umbrella. Regional itself is basically any time that we're injecting local anesthesia near nerves in order to block the impulse for pain relief. And so neuraxial, peripheral nerve block, local infiltration, those are our general types underneath that umbrella. Obviously local infiltration we're all familiar with when surgeons are just putting it under the skin to numb up, or if you need a mole removed or anything like that. Neuraxial is a term that you'll hear. That's anytime that we're putting the local around the spinal cord or centrally. Nerve root base could also be it, but essentially that's your spinal and epidural. And that's pretty much what neuraxial is, spinal or epidural. Everything else is going to be called a peripheral nerve block, which is our PNB there. So I'm trying to keep most of this focused on what we're actually going to be doing here. I'll talk a little bit about epidural stuff as well, but we'll jump straight into spinals. As I just defined, neuraxial, local anesthesia, bathing the nerve root specifically around the spinal cord. And there's lots of uses for that. Bless you.
Thank you.
Great, now we have to start the recording. When we're choosing whether to use spinal versus general, right below that I wrote there's a lot of study variability. It's been long debated on whether one is better than the other, and there's no right answer for that. There's risks versus benefits for both, and basically in general it usually comes down to patient preference, surgeon preference, as well as what we think will do best based on the patient's existing comorbidities, and what we want for post-op analgesia. So to talk about what the reason that we're here, when we discuss total joints specifically and what we'll be using spinals for, even though there's still lots of variability in the studies, a little bit more is coming out regularly showing that neuraxial is probably a little bit better than general. And then I listed a couple of specific examples. Less nausea and vomiting. Anytime that we're under general anesthesia, inhaled volatile anesthetic is a trigger for nausea and vomiting. So naturally, if we can avoid that, then you're going to have less nausea and vomiting. DVT risk, there's a little bit of less DVT risk. That still is up in the air because it compares newer studies with the general anesthesia studies it compares to are older, before all the regular DVT stuff was used, like STDs. Some studies have showed less failed same-day discharge, which is obviously important. We want to admit as few people as possible. Delirium, same as for nausea and vomiting. Anytime that we're not going all the way to sleep, then you're not going to be at that small risk of delirium. Less EBL, some studies have shown about 15% less. So spinal versus epidural, I put SAB in the parentheses there because you'll occasionally hear that as well. That just means subarachnoid block. If you hear SAB, just know that that's a spinal. It's an older term, so you might not hear it much. But if you can direct your attention to the picture on the right, I really like this picture because it shows basically a spinal, and I can break down a lot of different aspects for us here for an epidural as well. But just to talk about it from the right to the left, there's our skin, our subq, our various ligaments. We're going in between the spinous processes, and then you can see the first, since this isn't color, the first like big black line there is your actual epidural space. That is where we would stop if we were doing an epidural, and then flood that space with local anesthetic. For a spinal, as in this picture, we go a little bit farther past the dura into the subarachnoid space where our CSF is and inject a small amount of local anesthesia there. A couple other things that I like about this picture is, as you can see in the epidural space, there's no nerves. And so because of that, epidurals have a little bit more capability of being used for different surgeries, because we can go anywhere throughout the spine. And so you'll find epidurals outside of obstetrics used often for abdominal type surgeries, especially bowel things, because that helps us avoid opioids. Whereas the spinal, since it has to go into the subarachnoid space, that's where our spine is, we need to go below the spine. And so in this picture, as all spinals, we're well below the spine. Our spine ends at approximately L1, and then it turns into what you see in that picture, which is our floating nerve horse's tail called the cauda equina, and that's where we place our spinals. So generally, spinals are best used for belly button or below, specifically lower extremity surgeries because of that. I also like to just show, as you can see, we have to go in between the spinous processes, and so positioning becomes a critical aspect of being able to do it efficiently and safely. And so I figured I would talk about that in case anybody is able to help assist during these at any point, so that we know what's happening. So technique, the most common, the safest, the most efficient, less traumatic is a sitting posture. So we'll envision like we are getting the patient, we just brought them into the OR, we will sit them on the edge of the bed, and then give them a pillow, usually something to grab, helps to bring their arms forward, helps them arch their back out. And then for the lower back, in order to open up these spinous processes, we don't want good posture, we want it rounded out. And so usually like the cat, like the back of an angry cat, something like that. Hips relaxed backwards, and pelvis tilted back, basically. Head down, arms down, and relaxed. We will always have at least one assistant in the front, helping the patient maintain that. It's obviously a sterile procedure. They'll oftentimes get a little bit of sedation, so a little bit of a steady hand and helping them remember not to be reaching back for any reason is helpful. Once we place it, immediately after placement becomes important. Just to touch base briefly on the veracity of the type of local anesthetic that we use. We can use, veracity is the density of it, and so it can either be isobaric, hypobaric, or hyperbaric in comparison to the CSF, and that will determine how it reacts. We will almost always use hyperbaric. Isobaric is common as well, but hyperbaric means that it's more dense and it's going to drop from where we give it. That usually creates a safer, stronger, faster block, which is why we use it, and that's usually what comes in the kits. But so because of that, within about 30 seconds to a minute, it's settled where it's going to settle. And so as soon as we're done with the spinal, if we sat there for a minute, it would all go down, they would get a really strong saddle block, which would be unfortunate if we're trying to do a knee surgery. So what we'll do right when we're done, very quickly, we will lay them down, and we'll all help doing that and get them flat so that it sticks right around the lower lumbar and creates a nice block for them. So once that place is, it works quick, within a minute or two, you're getting a good dense block. Also with that, we see our effects of what's happening. So what's happening, you ask? That's a good question.
What's happening?
Okay, so mechanisms of action. So all local anesthesia does this. Obviously, it's an extreme effect for spinal since we're at the nerve root and in this CSF space. But we get a sensory block, a motor block, and an autonomic block. I'll talk about all three of them, but starting with sensory, there's two types of sensory, so I just like to touch base on that just because it's fun, I guess. Somatic and visceral. Somatic is our conscious stuff, our voluntary, our touch, this feels cold, this feels hot. Visceral is our internal things, our involuntary reflexes, such as our digestion and bladder stuff. Motor block, skeletal muscle, and then our autonomic, as I mentioned, leads to all of our side effects, and that's because our sympathetic nervous system gets blocked where the local takes effect, and so the parasympathetic nervous system basically takes over in an unopposed way. The bottom left, which I think it ended up a little bit blurry on ours, but is a quick diagram that I just think is pretty neat, and that shows the nerve distribution from our spine to our various organs. The left side is sympathetic, the right side is parasympathetic, and I like to just point it out because the parasympathetic side, as you can see, almost all of our nerves come from our craniosacral, so our top and bottom, versus the middle. Our sympathetic nervous system is primarily the thoracolumbar, which is why when we place the spinal or an epidural, generally our sympathetic side is getting blocked. Differential blockade, this is important for recovery. I listed it as 1, 2, 3. That's going to be how the block works. And so I think you guys are using alcohol pads to assess it. That's a common one. That will obviously assess the sympathetic blockade, which is the highest level that a spinal will go. And so temperature, the cold of the alcohol swab will often be what you can use. I feel like it basically dries out quickly. So usually you'll open it up, you'll be like, okay, does this feel cold? Swipe it, yes, no, kind of going up a little bit at a time until you get a yes answer. You can also even just use the corner of the alcohol pad before you've opened it, because it's a little bit pokey. And be like, does this feel sharp and pokey? And start working down that way, and that'll be a little bit more of a sensory. But wherever you find, let's stick with the cold, that sympathetic blockade, approximately 2 levels down will be sensory and 2 levels down will be motor. And so it's always in that phase and always in that level.
So 2 levels down and then 2 more levels?
Yep.
Okay, got it.
So if they're cold up to their belly button, which is T10-ish, then you know that they're getting sensory down to T12, and their motor block is probably still L2-ish. And the motor block doesn't always, it's not always completely equal, especially for total knees. I feel like generally they might be able to wiggle their toes a little bit earlier, but still can't move their knee. Okay, any questions about any of that? So side effects and treatment, as well as adverse effects. I want to preface with all of these are all very rare, especially in the setting that we'll be doing these, which is here for total joints. All of these statistics include where spinals are used worldwide, obstetrics, all that other various things. So starting with side effects and treatment. So cardiovascular wise, our most common items and probably the most important are our hypotension and bradycardia. About 1 in every 2, if you were to use all the statistics, get some degree of the hypotension. And that's because where the block occurs, you get decreased SVR, systemic vascular resistance, and increased peripheral blood pooling because your skeletal muscle is no longer working. So your blood stays down, causes some hypotension. About 10% get bradycardia. Most of that is usually direct blocking. Our cardio accelerator fibers are actually in T1 to T4, so the chance of that is a lot lower when we're doing lower blocks just for nerves or for knee surgery. Indirectly though, same thing. As soon as there's less blood, venous return coming to the heart, our myocardial pacemaker cells can cause our heart to slow down. I listed the other, so for treatment for that, generally preoperatively, you give a bolus. Increasing intravascular volume ahead of time, 250 to 500 mils, is going to help prevent that. that would obviously be our initial treatment, like it is for regular hypotension anyway in recovery.
And that shows up pretty quick.
It does, yeah. So the nice thing, same thing for most of these effects, and that's a good question. They will show up pretty quickly, or adverse-wise, usually a day afterwards. Which I'll cover that. I'll cover that for
A day?
well, for the rare things like back pain and stuff.
Oh, okay.
So there won't be a whole lot happening in the recovery side of things because it'll be starting to wear off. It'll have been hour to 2 hours.
Okay.
Yeah.
So if you're gonna see it, you're gonna see it like right afterwards.
Almost always, yeah.
Okay, got it.
Yep. And that's just as it's setting up.
Okay.
Pulmonary, I more just listed that because it's nice to have additional systems review on here, but essentially if the neuraxial anesthesia, that's our NA, reaches up into the thoracic area, then you're gonna numb up your accessory and intercostal muscles. And that sounds worse than it is. It's actually extremely asymptomatic unless the patient has some pretty severe pulmonary disease already.
Oh,
And that's because almost all of our breathing comes from our diaphragm. And so having our ribs a little numb doesn't hurt anything. The CNS, this is, I wanted to mention because, so that you guys are aware of it, obviously. After spinals and epidurals, we often will feel and appear a little bit sedated or a little bit sleepy. The unproven reason for that I listed there is the reticular activating system. That's just their hypothesis. But just know that a little bit sleepier afterwards is normal. Thermoregulation's altered the same as it is under general anesthesia. The process is slightly different. This time it's because of a sympathetic block, once again, that redistributes the blood to the periphery. And so we get cold because our blood goes that way. Our compensatory mechanisms are also blocked. Obviously, we can't shiver or vasoconstrict where we're numb. GI stuff, this is where I kind of mentioned the parasympathetic nervous system handles it more. You get a contracted gut, relaxed sphincters, normal peristalsis, which actually promotes GI motility. And so that's where abdominal surgeries, it's really nice to have these or epidurals that helps prevent occlusion afterwards and things like that. The renal system is basically of little clinical significance. It's not altered much as long as we keep renal blood flow, which is the same for general anesthesia, really. Okay, adverse effects and treatment. So, true permanent nerve injury is about 1 in 100,000, so that's why I put rare. And then generally, a lot of the big bad stuff, once again, although very rare, happens more in epidurals and in scenarios where we're trying to get higher blocks, and so OB stuff, because we need to get for labor a lot higher, or for C-sections up to T4 stuff. If there was a high spinal, just to touch base on it, we will circle back when we go over the last, because it's similar symptoms, but essentially hypotension, bradycardia, a patient feels like they can't breathe, and then potentially basically unconsciousness. That would once again happen almost instantly if it was going to happen. The risk here with total joints and being low is extremely, extremely low, nearly zero. And that's because we're going in the lumbar region and our total dose is so small. Which I didn't really mention that, but for a spinal, we're doing about 1 to 1.5 mils total. So it's not a lot. Whereas an epidural, to get it up and running, usually takes about 10 mils. We could get 10 to 20 for any sort of C-section type stuff very quickly. So the volumes are just so much different. Back pain, that can happen usually a day afterwards. These ones are the ones that generally are once they're home. Similar to if we start an IV, you get a little bit of a bruise. That's the same concept or thought process for a little bit of back pain. Generally a warm compress, if it was bothersome on the back, helps it. Paresthesias, that 1 in 100,000 is actually the permanent nerve injury, but During spinals, about 6% get some degree of paresthesia. Of those, there's a 0.1% chance of it remaining in recovery or post-op. Urinary retention, this one we may end up dealing with a little bit here, but a spinal doesn't increase the risk of that. Urinary retention is normal because they're numb in that area, so they can't feel the urge to go, and they don't have use of their detrusor muscle. But it directly corresponds to the duration of the block. So when the block wears off, all that function should come back normal. Urinary retention is the same risk factors as if they were having general anesthesia. Older males with BPH issues. And if you received opioids. Or neuraxial, if we were giving intrathecal opioids, that would as well, but we won't be doing that here or for the total needs. TNS stands for transient neurological symptoms. This is actually an etiology that's kind of unclear and not really well studied, but they think that essentially it's a little bit of toxicity to your nerves that happens. Lidocaine was implicated many years ago because it's such a high percentage, and so that's why we don't use it in spinals. But once the spinal resolves, it's usually 2 to 24 hours after. So once again at home, mild pain begins after resolution. It can be mild to extreme. They almost all resolve within a few days with ambulation and some NSAIDs.
Did you already say what you use?
I guess not. Bupivacaine.
Oh.
Yeah, it'll be bupivacaine for the spinals. Mepivacaine is often used as well, but that's a little bit newer, and it's a lot shorter acting. I think I've got it. We'll end up getting to that on the very last page. So I added it for just a little bit. Okay, post-oral puncture headache. Has anybody heard of this already? This is big in the OB world because we're doing epidurals. And so it's a bigger needle. If we go past the epidural space on accident, it's a known complication. If we punctured the dura, then you create a hole. CSF can leak through that and cause a headache. The headache, it's interesting since we're in the medical field, because as the CSF is leaking, it leaks faster than our body produces it and causes our brainstem to actually start to push down on our spine, and that's what creates the headache. And so a very, very clear symptom is the headache, and when you lay down, it gets relieved, and it gets relieved when we lay down because the pressure is relieved just from gravity. It is very rare. It says less than 3% risk, but that once again includes for everything. The higher risks happen if you are getting a lumbar puncture because of using larger needles. To put into perspective, for an epidural, we're using 2Es, which are usually 17 gauges. For our spinals here, we'll be using 25 to 27 gauge. And then I put a little picture there. The left needle is our standard, what you would think we use and was used decades ago. And we still have them available, but that's our cutting needle. For spinals, we now use mainly the other two on the right there that are pencil point. And that's helped diminish the risk substantially because as we go through the dura, pencil point actually just spreads the dura fibers instead of creating a hole. And so that helps minimize that risk. Generally, I did mention this one. I think the post-oral puncture headache really wouldn't be something that we would necessarily see here. Theoretically, you could, since they'll be up and walking and hanging around for a while. If it's mild, there's not much that we do except supportive measurements.
Uh-oh. Maybe. Is it one of hers? Yeah, it's not much, but I think Maggie's. Maggie's in her. Oh, because she's
What do we do? Well, I'll keep talking,
Yeah.
and then we'll switch pages afterwards, because we have like 3 or 4 more hours here. Okay, so post-oral puncture headache. If they say they have a headache, it's almost always mild, and it's just supportive treatment. keeping them hydrated, and then it goes away over time. If it was really, really severe, I have a really, 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 really bad headache, and it's with photophobia, I'm feeling nauseous because of it, neck stiffness, you could have a high suspicion for that, and then lay them flat and see if it goes completely away. And then if that's the case, then you could notify the surgeon and the anesthesia, and they can work on any additional remedies as needed, which
Once you lay them down, how long does it take for them to say?
it's almost instant.
Okay, so it's obvious.
Yeah, yeah, it's really obvious. Thank you. Okay. So we'll piece all that together at the end, but any questions about the spinal stuff? Okay. Then we'll cruise right into peripheral nerve blocks. So we'll start generically again, the overall benefits of them, the types we have, and then we'll talk about the two main ones that we're going to be doing here for total knees, all the side effects, and then we'll piece it all together as a full picture. So lots of benefits of peripheral nerve blocks. I've listed them all on the left there. Better pain control. Obviously, we're getting less narcotic use, and so that decreases a ton of side effects from, obviously, side effects of opioids, constipation, nausea, dizziness, drowsiness, and addiction. They've been shown to have anti-inflammatory effects from blocking the sympathetic nerve activity and cytokine stuff, which if you just think logistically, like if I'm in pain and I'm adrenalized, and then all of those are hormones and endorphins are shooting through your body, then that creates a cyclical inflammation response that we can block. And then a lot of studies have shown that our M&M decreases for the similar reasons that I mentioned for the spinal. We're able to, even if you're going to sleep, if you're numb and not in pain, then we can give you a lighter anesthetic. And so ultimately you're gonna have less cognitive dysfunction, less risk of cardiac or respiratory issues. The less thromboembolism is most likely basically directly linked to faster recovery, and so you're less immobile. So types of blocks for our shoulders, and what we'll be doing here, it's an interscalene primarily, which is our brachial plexus. We do have another 3 or 4 really regularly used one if we're working on the arm or wrist, or basically from the elbow down. For the knee, the primary one that the surgeons want here and what we use is our adductor canal block, which is a saphenous nerve, which is a branch of our femoral. Everything knee related, since we're walking, is going to be sensory only, because we're trying to not hurt the motor or cause any sort of quadriceps weakness since they need to walk. That is not the case for brachial plexus. For that, they don't need to use their shoulder. A lot of surgeons don't want them to for a certain number of days. They'll be around a brace and whatnot, and so we block the motor and sensory on that to give them complete pain relief. And then I just listed, so for knee surgery, there's a front and back aspect depending on how much the surgeons are helping with local. We've got what's called an IPAC for the knee, which is basically some branch of the sciatic stuff in the back. And just in general, we can essentially block anything from head to toe on a peripheral nerve block to help with pain control afterwards. Okay, so side effects and risks, just in general for nerve blocks, all once again extremely rare, especially now that we do them all ultrasound guided. We're no longer needing to do it blindly or with the nerve stimulator, and so we can see the nerves and make sure we're not getting too close to them, and then we can see the vessels and making sure that we're avoiding them. Because of that, nerve injury is extremely rare. Average there, if you do all the studies, 0.05%. A little more common to have some residual tingling that resolves up to a week later. All the blocks that we'll be doing here are superficial blocks, and so in the rare event that we hit a blood vessel, we could apply pressure without really any risk of hematoma. Allergic reactions exceptionally rare. Usually it's dermatitis type or a small rash if there was to be any sort of reaction. Infection, same once again as peripheral IVs, it's pretty negligible as we're doing it steroid. And I will touch base on last. That's our big one that we'll be discussing at the end, but we're giving a larger volume of local, and so there's a risk of toxicity. We do a lot of different things to prevent it, and we have a lovely plan in case of it happening that we'll cover. So we'll talk specifically about the inner scaling block. Same thing as we just did for the spinal, in case you're lucky enough to help us do one of those. So positioning wise, we are in a bed, we usually sit them up, we sit up about 30 degrees and turn our head the opposite direction. That helps open up the space for us and make it obvious. And inner scaling is aptly named because it's between the scaling muscles, between the anterior and middle scaling. You can't see it on the picture super well, but it's basically the first circle right next to the neck, where they're bundled up really well right there, and that's C5, 6, and 7. If you're helping us, and this is the same for any time we give any peripheral nerve block, if you're helping with positioning, we'll help describe what we want with the patient. Obviously, same, everything's sterile, we don't want them reaching up or anything like that. If you're helping give the block, it should never, meaning pushing the syringe, it should never ever be difficult to push. It should always be very easy, just like if you were pushing in an IV medication. And always aspirate every 5 mils, just hands down. And that helps make sure that nothing's migrated and that we're not intravascular. So for the inner scaling, it does have a little bit higher of a side effect profile. That's good to know pre-op and for recovery. And that's because everything is so close in the neck that inevitably some of the volume spreads and can lead to a decent number of side effects. I mentioned it does cause motor and sensory block. There is some variability based on provider and the cocktail that they use. Sometimes they won't be able to move their arm at all, and it'll be completely gone, and they won't even know it's their arm. Other times they may be able to move their arm pretty well. Obviously, the important part is that they're comfortable. Okay, so phrenic nerve blockade happens very, very commonly in this block. And so C3, C4, C5 is keep the diaphragm alive, and C5 is one of the nerves that we're targeting. And so oftentimes whatever side, the ipsilateral side that we're numbing up gets blocked, and that causes hemidiaphragmatic paralysis. That sounds bad, and it causes a lower ability to forcefully exhale, which is our forced vital capacity of approximately 25%. But usually it's very asymptomatic. The same as if the spinal got up to the intercostals. Very few patients report any sort of symptoms. Treatment's usually not required. If they do, and this is something that we talk to them about ahead of time so that they can expect it, and that usually helps diminish a lot of the anxiety.
Thank you.
And that's that they'll feel a little bit short of breath, anxious, maybe a little bit of slight discomfort around the abdomen on the block side. That's usually an indicator that that's happened. If that happens, it usually resolves in about an hour. And so the other nice thing is that if it happens, it will happen usually in pre-op once the block's set up, and by the time surgery's done, it's resolved. Another common one is called Horner syndrome. This can show up often in recovery. Essentially, part of the ganglion in the neck can get blocked if the local travels there. So specifically the sympathetic trunk. That causes symptoms that mimic a stroke. Ptosis of the eyelid, meiosis, and anhidrosis is the triad. But essentially their eyelid will droop. And their pupil will constrict on whatever side is the block. It'll be on the same side. And so know that that's a possible side effect. Yeah.
Not a stroke.
And you can do the rest of the neural exam, obviously, but that's a very, very possible and common thing to happen. hoarseness of the voice. I feel like if Horner syndrome happens, that's usually the most common time that you'll get the hoarseness as well, because at that point the spread, for whatever reason, has spread. And so that will happen if it ends up going same side on the recurrent laryngeal nerve and just numbs it up. That will usually go away after an hour or two as well. The basal gyrus reflex, I just always like to mention, if you sit a patient up who's had the nerve block quickly, it can cause some reflex hypotension and bradycardia.
Okay.
Usually, once again, by the time you're in recovery, it's set up enough and the body's compensated, and so you're not gonna have that effect. But just know if they were completely flat and then you went, whoop,
Like
that's potential to cause a little bit of bradycardia. And then our local anesthetic toxicity, again, I listed, but we'll talk about it at the end. And then I did, if you guys want to look at the other picture on there, that was just to show the dermatome spread of what happens for interscaling. And the reason we don't necessarily use it if we go below the elbow is because the lower trunk is missed. And so it's basically only the upper half of the circumference of your arm that gets blocked.
So it's mostly shoulder.
Yep, it'll almost always just be exclusively shoulder. We'll move it down that same brachial plexus as we go down the arm, and then we get less side effects, but can still numb up the arm better. So for example, if there was a wrist fracture we were treating, we might go just right above the clavicle, or right below the clavicle, or in the armpit instead of up in the neck, and we'll get a block that would treat them better without the risk of Horner syndrome or the phrenic nerve block.
Oh, okay, so you just move it down.
Yeah, 'cause it's still bundled up nicely. Okay, the adductor canal block. This one is our nerve block for obviously our total knee, or really anything from the knee below. It's the saphenous nerve, which goes on the medial side of the leg. As I mentioned, it's a branch of the femoral nerve, and it's sensory only, which is why we use it. Because it's sensory and doesn't block all the motor, we can't numb up the leg completely. And so, I'm not sure what the surgeons are doing here, but they'll most likely place a periarticular injection during surgery that helps with the additional pain and discomfort and the pain in the back of the knee. But we can also block those areas via other sensory ones, but the adductor canal block is kind of the staple. Positioning for that, just for funsies. In pre-op, basically you want a frog leg. So we have them just frog leg out. We go about mid-thigh. If we went higher, then we're gonna hit the femoral nerve and cause motor weakness. If we go lower, then usually the saphenous is branched out already and we might miss the main part of it. But about midway between the knee and the inguinal crease, and we block just right on the medial side of the knee. That lasts about 24 hours. And I listed, so for side effects, same thing, if you were helping with the injection portion of that, it should always be easy, aspirate every 5 mils. We will give anywhere from 10 to 20 mils in that spot, depending on how the spread is looking and whether we're in the actual canal. Foot drop is a very, very rare risk. It's actually more common if we were to do blocks in the back of the knee because it's related towards the perennial nerve, which is sciatic. I listed it there. It's not much of a concern for the adductor, but it is a concern for total knees. And so in recovery, as the spinal's wearing off, we don't want foot drop. So that's something just to be aware of. It can be a surgical complication. And then I listed last again. So I wanted to just put kind of a big picture on the right there of if we piece together everything we kind of just talked about for knee surgery in general. It takes a full multimodal approach. We're doing a spinal, we're doing a nerve block, the surgeon's still adding his periarticular injection or some sort of local for the skin, and then we're giving our usual systemic analgesics to try and help minimize opioids as much as possible. So you're getting your NSAIDs, your Tylenol, maybe some ketamine, maybe some magnesium, some sort of oral stuff like oxycodone, and all that's getting on board in order for them to be able to walk quickly. And then I just want to touch base briefly on local anesthesia in general. All the local anesthetics that we use in today's day and age all have a very large therapeutic index, so they're all very safe to give. We can give large volumes of them. By using ultrasound guidance like we get to now, that actually helps us minimize volume because we're not guessing. We can make sure we're placing it exactly next to the nerve. And so that allows us to use a lot less, which helps keep us below our level of toxicity. Just for funsies, there's actually a couple different main types of local anesthesia. Even though it's all a local anesthesia umbrella, they fall very distinctly into two categories of what's called amides versus esters. And if two eyes, then it's an amide, is the fun phrase. And so I listed some, obviously bupivacaine, lidocaine, mepivacaine, ropivacaine. I capitalized the eyes, which actually made it look worse on here, but you can see that there's two eyes in all of them.
No, it's completely not readable. I'm like, what is that one? I've never seen that one. Bolviolate.
So that's...
No, but yeah, I know what you're trying to say. Yeah.
Should have bolded it.
Yeah, it's okay.
Cut that from the recording.
He looks Hispanic.
So that's classified as an amide. That's just its chemical structure.
I thought you were laughing at me. I'm sorry.
So these are metabolized in the liver. The other kind is
I thought we were
esters.
done with this. Yeah. But you know, I almost read it as.
I listed.
It's okay.
Hey, in the front.
Yeah.
Do you want to pause the recording? Just kidding. Okay, so esters is the other kind, propane, cocaine, tetracaine. These are usually the densest side of things, right? Novocaine, only one eye, so it's an ester. And those are metabolized by pseudocholinesterase, which is an enzyme in our plasma. And it's actually the same enzyme that metabolizes phenylcholine, interestingly. These two groups do not have cross sensitivity. So when people say that it doesn't, a regular one, and somebody says at the dentist they have to numb me up over and over again, it doesn't work. Most likely they're using Novocaine. And so our stuff that we use here, lidocaine, because it's an amide instead of an ester, it works fine and you never hear any complaints about it. And that's often why. So that was just kind of some fun facts.
Oh, so the Novocaine is part of that ester stuff?
Mm-hmm.
Oh, we should have put that on there.
Okay, the picture on the right, just to show, so our bupivacaine and ropivacaine are our most commonly used for peripheral nerve blocks. As we mentioned earlier, bupivacaine is going to be our usual for our spinals. And there's a wide variance on duration of how long they work. But essentially, for a spinal, we're going to get usually around 2 hours. Of like 90 minutes to 150. And then for the nerve blocks, using those, we're going to get 18 to 24 hours. So there's a lot of different things that we do to prevent local anesthetic toxicity, starting with knowing, obviously, our total maximum dose, and then we stay as far away from that as possible. And we're able to do that by, as I mentioned earlier, using low volumes because of ultrasound. And then we also safely, when we are administering them, aspirate to make sure that we're not intravascular. So we have a lot of reasons to not ever end up in a toxic standpoint. But in the rare event that we did, I don't know if you have these ones.
Is that what you'd see? Pass them on or just here? You know.
Was it on your chair?
Local anesthetic toxicity. And that's the
I don't think
same
we have any extra.
thing
This one's
that
for me
the
too. stuff.
right?
Or I can talk about it on this one if you want. Okay, so this is just a quick go-to for us to be able to talk about it. So, initial symptoms. The nice thing is, generally, if this happens, it'll happen basically right away when we're doing the nerve block. And then the neurological symptoms is where we can start, and I feel like they put them upside down. The first things that you're gonna get are some numbness around the lips,
Yeah.
the tongue, you're gonna get that metallic taste in your mouth, and then you're gonna get some ringing in your ears. Those are gonna be the first three indications that we're injecting where we shouldn't be, most likely. After that, it can very quickly get worse, and that's where you get your altered mental status, potentially seizures, unconsciousness, and then at the same time you get your cardiovascular collapse of bradycardia and hypotension. So as I mentioned, we do a lot of things to prevent it. Let's say that we're sitting there and we're injecting, and we get negative aspiration, and then we're injecting, and then the patient starts to complain of these things. The first things we're going to do is obviously stop
Right.
and call for help.
Right.
Then, just like MH is go get the dantrolene or Ryanodex, for last it's go get the intralipids. Intralipids is basically a cure-all for it, in that it causes the local anesthesia to bind to the lipids instead of to
Is it a
our
bag,
cells.
or is it like, what does it come in?
So we need to figure that out here, but yeah, it's in a bag.
Like
I don't know
like
where
a saline?
it's sitting. I'm sure it's
Yeah.
in carb.
There's a little kit in the back.
Okay, good. Yeah, it's white.
It's in the code card.
Okay. I
Looks
think
like
we're
a
planning.
TPN.
We're planning on. Yeah, actually.
Yeah, okay, okay.
And the quickest way generally, we'll have to see when we. I think there's planning to do drills and such, but the quickest thing is to draw up and push it, and you do need to draw it through a filter, just like TPN, actually. And so lipid emulsion is actually about halfway down this sheet, and they try to create a simple. Basically, it's 1.5 mils per kg, but if you're at least 70 kilograms, you just draw up 100 mils and push it. And then you can adjust from there, keep giving more, or start an infusion. And that's the mainstay. The rest of the things are treating the symptoms that the patient has, just like you would do for ACLS. So if the patient started having a seizure, you still would prioritize while somebody's getting that and giving it, because that's the treatment. We could also give benzos or in order to treat seizures.
Side, turn off the lights.
Yeah.
Let me just ask it. So, I mean, is it kind of like Narcan, like you give it and then if you don't keep giving it, the symptoms come back because it's just a toxicity? So you have
Yes.
to keep giving it?
So
Or
that's
you
why.
do it in-
So it's, I would, if I was just, it's like Narcan in that it can wear off. And so after you give the first, then you start an infusion.
Okay.
Yeah. And that's really about it, unless anybody has any questions.
Would that be you administering that lipid thing, if that came to it? Or would that be a
It's a-
nurse job, but like, is that in our scope?
It very much depends. So ideally, obviously, if it was happening right then, let's say, we stop, and then I would
Probably need an
lead,
order
I would
anyway.
lead through it. I'd be like, go get the
Right,
intralipids,
okay.
while, depending on what the patient's doing, if they're starting to not do great, we need to secure their airway. I'm working on that while you get the lipids, and then we're like, go ahead and give 100 mils real quick. Doesn't happen now. While,
Okay, I
while
got
we,
a
while we
hotline or
intubate,
anything?
or if we have to start CPR, we start the CPR process.
Are we treating last as a scenario?
Yes. And then would they need to go to the hospital for observation after that then?
Yeah.
Yeah, okay.
Just like any major.
Major
Complications.
complications, okay,
Yeah.
got it.
Did you guys have one back?
Oh, hopefully it won't happen.
So I'll just do the one.
No, I just did
Okay.
one because the other page was made it sloppy.
Okay.
When I just wanted to go through the basics of it. Yeah. Good question. Good question. Okay, does anybody have any questions about any of the process or any of everything?
No, that's super helpful. It's helpful
Okay.
to see like pictures of where you guys are going.
So when you talk about like injecting and aspirating every 5 mils,
Yeah.
like, does that, you should see the medicine coming back up,
No.
no blood, or what do you see when
No.
you aspirate?
You
then,
won't see
or-
anything.
You won't see
Yeah,
anything?
it'll
So
fill-
as long as you don't
you'll
see
pull.
anything, then you'll just,
You'll pull and you won't be able to.
okay, oh, got it, okay, okay.
It won't just pull and, yeah, it's
Right.
an airtight space.
Ah, okay. That makes sense.
Yeah, good question.
I like the printout. Thank you.
Thanks, everybody.